Hello, my name is Tim Mikas. I'm a chest radiologist with Allegheny Health Network in Pittsburgh, Pennsylvania. And today I'm going to be talking to you about imaging features of electronic cigarette or vaping associated lung injury, also called EVALI. This is my disclosure, which does not have any bearing on this talk. We're going to talk briefly about what e-cigarettes or electronic nicotine delivery systems are, and talk about who is at risk of getting this disease. And then we're going to use some cases to demonstrate the imaging patterns, as well as talk about the clinical definition of what EVALI is. So these delivery systems, also called e-cigarettes and a bunch of different names, were initially introduced into the European and US markets back in 2006 to 2007. Instead of burning leaves like tobacco, these aerosolize or vaporize nicotine-containing liquids. And often people add different flavoring additives, also called juices, to the devices to make them more flavorful or taste better. Additionally, people are now using these devices to aerosolize marijuana or THC products. And literally on the market now, there are hundreds of devices and thousands of different juices available. E-cigarette usage is much more common in younger patients, although it was originally marketed to adults. And in fact, a recent survey in 2018 showed about 20% of high school students have tried or were currently using e-cigarettes, and about 1 in 5 were using it within the past 30 days. So that it was declared an epidemic in high school age patients to try and really limit the marketing and selling the devices to them. But unfortunately, it still is being used today by millions of young people across the US and the world. EVALI as a clinical problem was sporadically probably reported and under-recognized in the literature up until about 2019, when in August there was a breakout of lung disease across the US that was associated with vaping. Patients presented with nonspecific clinical symptoms, usually mimicking a viral illness, but rapidly progressed. Usually they complain about respiratory complaints, but also gastrointestinal disturbances are very common, as well as fever and fatigue. In general, what we're looking for to diagnose somebody with EVALI is to have a history of vaping or electronic cigarette use within 90 days, although a closer time point to the onset of symptoms is usually better. There's an abnormality of chest imaging that can't be explained by other causes, such as infection, underlying autoimmune diseases, or malignancy. Usually the patients do much better following stopping of using the e-cigarettes and also with corticosteroids, although there are reports of patients having long-term lung damage or even mortality from the e-cigarette use. So both as far as imaging patterns as well as the histology, the underlying EVALI has a lot of different patterns. And so for the purposes of the talk, we're going to talk about the most common patterns here in the upper part of the slide and focus a little bit more on diffuse cellular damage and organized pneumonia pattern, which is the most common pattern. But we'll also talk about these other patterns here as well. But you'll notice throughout the slide that there is going to be some overlap in some of the imaging features, which makes this a particularly challenging diagnosis and why it's a diagnosis of exclusion. So first we'll start out with diffuse alveolar damage or with or without organized pneumonia, which is the most common imaging pattern that's been described so far. Recently, it's also been called acute lung injury, so you'll see that in the literature as well. What we're looking for here, the key features are multifocal or diffuse ground glass opacities. Usually can also be seen in the setting with consolidation. And in particular, there's a subpleural sparing that can occur, both periphery of the lungs as well as in the central aspects of the lungs and along the bronchovascular bundles. And that subpleural sparing is going to be a real key imaging feature to help us try and identify this from other kind of non-specific diseases. Septal thickening, both inter and intralobular septal thickening can be present, as well as central lobular nodules. So let's look at some case examples from our site. This is a young woman who presented to the emergency room with about 10 days of nausea, vomiting, fever, and mild shortness of breath. She is a daily THC vaping user. And we can see that in the lungs, there's this kind of diffuse haziness and interstitial abnormality, but really sparing the peripheral edges of both lungs, as well as the borders of the heart. You kind of see that a little bit better, these dashed lines to draw your attention to it. She had a CT examination in the emergency room, which shows to better extent the ground glass opacity present bilaterally, and really the exquisite peripheral subpleural sparing that's seen in the lungs, both at the edges of the lungs, but also the edges of the lungs more along the medial reflection of the mediastinum. This is really commonly reported with the diffuse alveolar damage pattern. This is a bit of a more extreme case. This is an 18-year-old young man who has been using vaping tobacco and THC products for the past 2 years, who reports with an acute onset of new shortness of breath, fever, and epigastric pain. In the emergency room, this chest x-ray was obtained showing interstitial thickening with curly beeline formation at the right lung base here, as well as patchy areas of airspace opacity greatest in the left lower lobe. A CT was obtained showing these same features: ground glass opacity and consolidation, sparing of the periphery of the lungs, really obvious here, as well as areas of scattered central alveolar thickening. In the more consolidated left lower lobe, there are areas of almost early traction bronchiectasis suggestive of organization. The patient did well and promised to stop smoking and was discharged from the hospital after about 3 days. He presented about 3 months later with another, again, acute onset of constitutional symptoms as well as epigastric pain, but this time more shortness of breath. Promising he has not been smoking any kind of vaping products at all. CT obtained in the emergency room, and then also follow-up in-house images a few days after that demonstrate this profound, much more coarse septal thickening and much more ground glass opacity, with areas of consolidation in the lungs, almost forming atoll sign like organizing pneumonia. He goes on to develop a few days later some pleural effusions, much more pronounced smooth interlobular septal thickening, ground glass kind of nodularity filling these secondary pulmonary lobules, and extensive consolidation. Because all the clinical workup was really failing to find a diagnosis, as an 18-year-old, he actually underwent an open lung biopsy to make sure there wasn't no underlying connective tissue disease that was being missed. Pathology report shows areas of diffuse interstitial and intraalveolar fibroblastic proliferation, as well as marked proliferation of reactive type pneumocytes. These are findings which are a hallmark of acute phase of diffuse alveolar damage. After the lung biopsy, about a week later, after really intense questioning, he did finally admit that he'd been using vaping products throughout the entire time leading up to this. And so this was a patient who actually had this E-valley lung injury twice. The next most common pattern that's been reported is the subacute hypersensitivity pneumonitis-like pattern. This is not a true hypersensitivity pneumonitis on histopathology, but the imaging features are very similar to subacute HP, seeing ground glass opacities, often poorly defined central alveolar nodules, typically in the upper lungs. We also see areas of mosaic attenuation or air trapping, interlobular low attenuation. So here's an example of similar imaging features. So similar clinical presentation in young male patient with shortness of breath and abdominal pain. Comes in with this abnormal X-ray showing opacities in the lower lobes, but also fine interstitial opacities in mid to upper lungs. CT done in the emergency room shows changes both of an HP pattern as well as alveolar damage. In the right lung, we see these fine, tiny central alveolar nodules scattered in the right upper lobe here, as well as peripheral areas of ground glass opacity, which have this really subpleural sparing, also sparing along the bronchovascular bundle, and really kind of heterogeneous, almost lobular, low attenuation areas, which are suggestive of air trapping. This is a very suggestive pattern of these subacute HP-like pattern of diffuse alveolar that's been reported with E-valley. Here's another patient, a young woman, a really subtle X-ray abnormality, very faint interstitial thickening in the lungs. CT examination performed at the same time, same date, shows a better extent of the ground glass opacity in the septal thickening. But additionally, there are these peripheral areas of lobular sparing in the lungs, and also a fine mosaic attenuation pattern, which is seen diffusely throughout the lungs, suggestive of underlying small airway disease. Of note, she really did not have any central lobular nodules that were seen in this case, but this is another example which can be seen in this kind of subacute HP-like lung injury. Acute eosinophilic pneumonia is a very uncommon disease which was reported in patients who smoke traditional cigarettes, usually after binge smoking or starting up smoking cigarettes. It is also now being seen in vaping lung disease. And the hallmark of the suggestion to help you suggest acute eosinophilic pneumonia, really look for septal thickening and pleural effusions in a patient with otherwise normal left ventricular function and normal left heart. Patients also have ground glass and consolidated opacity in lungs, usually bilateral and usually symmetric. So this is a case as a young woman who presented in an outside hospital before being transferred to our system with really acute upper abdominal symptoms. There's a high suspicion for acute cholecystitis, long-term marijuana vaping user, and who has a new onset. And on the CT images from the abdominal and pelvic CT, we see these ground glass opacities, again, with pronounced peripheral sparing present bilaterally. She decompensated at the outside hospital and transferred for more urgent care, higher level of care. 48 hours when she's transferred to our system. Now she's intubated, much more pronounced opacity from a combination of new pleural effusions, consolidation with their bronchograms in the lower lobes, as well as much more pronounced interstitial abnormality throughout the remainder of the lungs. Infection was ruled out. Patient was treated with antibiotics and corticosteroids and started getting better, and she's extubated. A CT was obtained another 2 days after that X-ray, showing the effusions again, small in volume, normal heart size, and again, diffuse, smooth interlobular septal thickening and ground glass opacities. Some of the ground glass opacities really get near but do not get to the very edge of the lungs. And this, again, this imaging pattern, especially with the history, is very suggestive of the acute eosinophilic pneumonia pattern. Patient markedly improved after a few days of corticosteroid treatment, and repeat imaging showed totally normal lungs afterwards, and after she quit smoking. The final pattern we're going to touch on is a diffuse alveolar hemorrhage pattern. And this is a difficult presentation, both from an imaging and a clinical presentation side of things, because it's very nonspecific. Patients present with cough and fever and dyspnea, but importantly, hemoptysis may be absent in about a third of the cases. Imaging clues that'll help us make this diagnosis is looking for consolidative opacities, usually asymmetric, but sometimes we get lucky and see these kind of fluffy looking central lobular nodules that tend to fill up the secondary pulmonary lobules. And sometimes we see septal thickening as that blood gets taken up by the interstitium. So this is a case, 37-year-old male, long-term both marijuana and nicotine vaping user, who presented to the emergency room, again, shortness of breath and epigastric pain. The PE study was done in the emergency room and really showed no PE or other acute findings in the upper abdomen, but showed this really pronounced ground glass opacities in the lungs, really extensive peripheral sparing. And what you see within the ground glass opacity is fine intralobular septal thickening, also these very loosely organized ground glass nodules really filling out the secondary pulmonary lobules. These again this is a very suggestive pattern of alveolar hemorrhage. So take-home points for today. E-cigarette use is very common and probably more common than we would expect, and especially in younger patients. The clinical presentation can be very difficult and nonspecific, but the imaging patterns can be helpful, especially if we see this DAD pattern with the subpleural sparing. That can be useful to help alert our clinical colleagues to press for a vaping history. These are my references, and I'd like to introduce our next speaker, Dr. Scott Simpson from the University of Pennsylvania in Philadelphia, talking about high-yield signs in thoracic imaging. Thank you for your